Let's let one rip here tonight, Era.
Hold on.
We're gonna have some fun. Product placement.
Right. We are now live. Hi, everybody. Thank you for joining us for our Ask the Hematologist session. Remember, if you have any questions or have anything that you'd like answered, you can put it in the comments, you can chat it to us, you can send an email, many different ways that you're able to do that. But go ahead and make sure to submit your questions so we're able to answer any of those concerns you do have. We have two great hematologists with us currently. We have two more that might join. They're currently treating patients, so we didn't want to pull them away from that. If you guys would want to go ahead and introduce yourselves.
Go ahead, Era, you go first.
All right. Hey, everyone. I'm Metjian. I'm a hematologist at the University of Colorado at the Entrance Medical Campus in Denver, or Aurora, Colorado. And as everyone else here, a very active interest and passion for diagnosing, treating, and managing and researching TTP. So glad everyone is here.
Hello, everybody. I'm Spirit Cataland. I'm the Columbus, Ohio version of Era Metjian. So I'm involved in clinical care, research, diagnosis, and treatment of patients with TTP. And again, something we're very passionate about. Radhika, we're just introducing ourselves, so your turn.
Yeah, thank you. Hi, everyone. This is Radhika Gangaraju. I'm a hematologist at University of Alabama at Birmingham. And as everyone else in the call, I'm passionate about TTP and other benign hematologic disorders.
All right. Well, thank you guys for being here today. I really appreciate it. First thing I want to start off with is kind of the topic of the moment. And I know we've addressed it a few times, but I've also gotten the question. So is it safe for a patient with TTP to get the COVID-19 vaccine? Does it matter if they get the Johnson & Johnson or if they get the Pfizer or Moderna? And do you think that a TTP patient should qualify for a booster shot at this time? So there's a whole little breakdown there if you guys want to go through it.
Well, I can go ahead and start. I mean, in general, it's safe for a patient with a history of TTP to get a vaccine. We've had an experience where a patient who had undetectable item TS13 activity got a vaccine that led to, we think, a relapse of her TTP. So in general, you should get the vaccine. I think that's a unique case, and that shouldn't be meant to discourage you. I think if you're following the Adam TS13 activity, might make sense to use that as a guide. And if you are less than 10 or even 20%, have a discussion with your physician about the risks and benefits of it. We've had patients get vaccinated below 10% and not develop a relapse. So you have to use that with some caution. So it's something to think about. What do you guys think?
I agree. I have been encouraging all of my patients to get the vaccine because I think right now the harms of getting COVID-19 are much more than side effects from the vaccine. And I think in TTP, we don't even know if the vaccine causes any side effects. There are very few reports and I guess like from personal experiences, there are very few cases of TTP that have relapsed after the vaccine. So I think right now the recommendation is to go ahead and have the vaccine. And in regards to booster, I think most of our TTP patients would qualify for a booster. Again, it depends on how, I guess like how far from now you were treated with immunosuppressive therapy, because some patients may not have received any treatment over the last 5 years or so, and they may have been in relapse for long duration. In those patients, we don't clearly know the benefit of booster, but I think we are all moving towards booster shot for everyone in the next couple of months. But if you have been treated with immunosuppressive medications in the last couple of years, I would highly encourage you to get a booster dose.
Yeah, I agree with all that. You know, when we look at the fact that over 5 billion doses have been given of the vaccines of one of the four, and that given the likelihood of how much worse COVID would be, it's an unequivocal yes. Get the COVID shot, and getting a booster to me is no different than getting a booster for your tetanus or for the flu shot that we get once a year. I think if someone else wants to chime in on this also, I think if you have recently received rituximab, if you've just completed your cycle, then it might not be, you may not get as much benefit from it. And all we're really doing is just putting a hole in your arm. In that case, I would probably say hold off on it. And when would be the optimal time to get it after the rituximab? I think, people have said around 6 months, maybe probably a little bit longer if you really want to get an effective response. But otherwise, if it's been quite some time, if you've had TTP in the past and your ADAMTS13 levels are well within normal range, I think it's a no-brainer to get the COVID shot. Was there one thing in terms of timing after rituximab?
Yeah, I think we follow that 6-month gap as well with rituximab, but I think most of this evidence comes from rheumatology patients, and because that's one of the other specialties where rituximab is commonly used. And it appears that people who were treated with rituximab may not mount an immune response to the vaccine, and that's the reason why we are asking you to wait for 4 to 6 months after the rituximab dose to receive your dose of vaccine.
I think I echo what Radhika said. Anything that you're going to say the vaccine might rarely cause is going to be far more likely to be caused by getting a full-blown COVID infection. So you have to remember that. And it's just not a safe way to go about to say you're going to isolate yourself and avoid it. It's just not possible to avoid it.
All right.
So get vaccinated.
Yeah. Awesome. All right. So we have a couple questions about Rituxan and ADAMTS13. So at what level would you guys look at putting on a patient on any prophylactic therapy, and what type of prophylactic therapies would you use? So this is a patient who is otherwise in remission, but their platelets their ADAMTS13 starts declining, all other platelets and their LDH looks fine. What would you do with this patient?
I guess I'll start. I mean, we do know that low ADAMTS13 activity, less than 10%, it's been probably extended to 20%. Doesn't mean relapse is going to occur, but it certainly increases the risk for relapse. Our general approach is to talk to patients when they are less than 20% or dropping steadily and approaching that, and they've got a history of relapse, to really talk about the risks and benefits of doing it, and both sides of it make good decision. It's certainly reasonable to do it. It may be reasonable not to do it based on individual patient circumstances, but in general, that's the approach that's being applied, is to use rituximab as sort of the main therapy for prophylaxis. There's been some studies, we've done some of them with cyclosporin, can be effective, but you have to keep on taking it. And there's been a lot of studies with other things that are, I guess, less well studied and less familiar with, how well the effects are long term. But it's a pretty individualized approach, I think, between the physician and patient. We don't absolutely know who needs it. What do you guys think?
I use a cutoff of 20 as well. I think I start the conversation with the patient when they're close to 30. I kind of prepared them that maybe we are in a situation where the level would drop in the next few months or so. So I guess they're more prepared when we start the conversation early. And I think 20 has been my cutoff as well to start preemptive rituximab. That being said, I have had few patients who were in their 30s for several months and even a year, and they haven't relapsed and their level hasn't gone down below that 30 level. So, and some of them have actually improved their level spontaneously into the 50s.
Yes.
So, and I'm sure we have all had these experiences where ADAMTS13 fluctuates, and not necessarily mean that they are guaranteed for a relapse. I think it just means that they're at risk of relapse, and we don't actually know how far or how long they have until that relapse happens. And I think most of the TTP patients are scared of that relapse happening, and they absolutely want that to happen. So I think we try to proactively treat it in most circumstances.
Okay. And so if a patient has another autoimmune disease, specifically if the patient has rheumatoid arthritis, and they're trying to decide between Humira or Rituxan to treat it, would using Rituxan also help their TTP prophylactically, even if their ADAMTS13 is normal? Or would it be kind of nil?
think you probably don't want to ask a hematologist how best to treat your rheumatoid arthritis is probably the first thing I would say. And I think the better point to be made is if, in general, when there's an autoimmune disease that may have led to TTP or vice versa, if that autoimmune disease is better controlled, you're less likely, we think, to have a relapse of TTP. So whatever the rheumatologist thinks to best treat the rheumatoid arthritis, I think is the right way to go.
I agree. I guess depending on how severe the rheumatoid arthritis is, whatever is best for the rheumatoid arthritis has to be given priority.
This is something that comes up frequently. I mean, if the person has normal hemoglobin, normal platelet count, ADAMTS13 is stone cold, well within the normal range. I frequently tell my patients is that you had a history of TTP. Yes, we always worry about the risk of an immunologic relapse. We worry about the risk of a hematologic relapse, but that doesn't mean because someone had TTP that you should still get the standard of care with anything. If something is indicated, whether it's for rheumatoid arthritis, your liver, your kidney, your heart, they need to do a biopsy, you need an antibiotic for this. None of that should ever be delayed, questioned, or held because of this past history of TTP. If someone's rheumatoid arthritis is at that point where they need disease modifying agents for it, then by all means, you should get that done, because not treating it is not going to make anything better.
Excellent point.
Perfect. Now, talking about ADAMTS13 again, is there any concern for an ADAMTS13 to be too high? So the patient is aware that, having low or undetectable it puts them at risk, but what if it's above 100%, like 150%?
I don't think there's any evidence that having, or quite honestly, knowing what a high level is. Range of normal can be sort of a moving target. It's each local lab usually checking 100 or 200 people to sort of find a mean or a median to find out what that normal range should be. I don't think we know that, but I think, as Radhika already said earlier, you have to be careful. The ADAMTS13 in remission outside of treatment can fluctuate greatly up and down. So it's more important to focus on the trend rather than just one reading, I would say. But as far as high levels, we're getting some information from an ongoing clinical trial using recombinant ADAMTS13. I think the answer is probably going to be there's not a problem, but we don't know that for sure.
Okay. And do you want to just touch base on what it would mean for recombinant ADAMTS13 and what recombinant ADAMTS13 is? No.
Yeah, recombinant is just essentially the ADAMTS13 protease that's made in a lab. So it's made in a lab and infused. So it's not your own native, what your body's making, but it's what's made in a lab and infused, like an infusion of some other treatment or drug, meant to do the same thing that your own native ADAMTS13 protease would do, which is cleave those big pieces of viral liver factor down to the normal size pieces.
All right. So a patient recently received a Moderna vaccine and their ADAMTS13 has steadily increased since they received it. Do you think there's any connection there, or is that just random good luck?
Or they had a good hematologist who knew how to treat TTP.
It's a good question. It's hard to make associations like that. We deal with this with clinical trials all the time, and that's why you need, people don't like placebo-controlled studies, but you need them for sort of reasons like this. Just like if you got something, whatever it is, after a vaccine, it doesn't automatically mean it came from the vaccine. It could have happened regardless of that vaccine or not. So okay. It's hard to know for certain.
All right, let's talk about another popular subject here, relapses. So the first question is, what percentage of people relapse? So the statistic quoted here is 30 to 40%. And then, so that would mean that 60 to 70% of people only ever have one episode. And then if you have a relapse in your first year, you're more likely to have more relapses in the future. And then the severity of relapse. So we'll kind of break it up into different parts there. I guess the first question is, how many people actually relapse? And is it possible to only ever have one TTP episode?
Yes, it's possible to only have one TTP episode. That is possible. And if it's, I think that unfortunately the answer is not going to be the most definitive one. You're going to say it depends. For someone in whom this was a random event, they were treated, with steroids plus minus rituximab, their ADAM-TS13 goes up and stays up. And I think we all feel sort of more comfortable that the longer that someone's ADAM-TS13 levels have gone up and stayed up and have not fluctuated, that their risk of relapse starts to go down. I don't know if we can say definitively over the course of 20, 30, 40 years. I mean, ADAM-TS13 has not been out that long. We've not been checking it that long. So we can't really say over the course of a lifetime. But I think I would say that most of us feel very comfortable. If it's been years since an event, the likelihood becomes lower as time goes on. What does everyone else think on that one?
I agree. I think we know that most of the relapses occur within the first year. And as Dr. Metjian was mentioning, most people actually don't have that relapse. And it can vary from 6 months or even less than 6 months to several years after that first episode. And the only biomarker we have right now is monitoring of ADAM-TS13 level. And there are some downsides of even monitoring ADAM-TS13 because there are several patients who do not relapse in spite of having a low ADAM-TS13 level. But at least that's the better one among the other biomarkers that we have right now for monitoring of patients who are in remission.
I agree. If you do it, as others have said, you're likely to do it in the first year, about a 50-50 shot, but it's always still possible. And autoimmune diseases can be sort of strange, and unpredictable at times.
All right. And
what was the next part?
the next part is if you have a relapse in your first year, are you more likely to have more relapses? But if you relapse at a younger age, are you more at risk to have more severe disease? And does one relapse indicate that you're going to have, if you have one relapse, are you going to have more severe relapses in the future? Like, does it get subsequently worse each time?
You would think and you would predict that if you have more than one episode, it predicts a greater risk of more. And actually, we're in the process of studying this exact idea and modeling with about 17 or 18 risk factors to narrow down what best predicts relapse. And surprisingly, multiple relapses previously didn't really predict your greater risk of relapse in this 3-month relapse model. So it didn't seem to predict it, but there have been some studies, and the same work we've done also suggests that the younger you are, the greater the risk of relapse is. So if you're younger, you're more likely to relapse. I think in general, most of us would say if someone has relapsed 2 or 3 times, they're more likely to do it again than someone who's only had one event 10 years ago. But it's still impossible to predict. And it's why a lot of research is going in to try to more accurately predict relapse and who needs to be preventively or prophylactically treated and who just can be watched.
I'm not sure if this is in the same vein as the question, but I mean, what we have seen is that, yes, we always worry about relapses, but, generally the literature has shown that for patients who, the relapses we tend to catch earlier, we tend to treat more aggressively just because TTP is, before the first diagnosis, like who knew? Who could even pronounce what was TTP? But there is this sort of, once bitten, twice shy. And I think that now that we know, the person knows, there's a level of vigilance that never was there before. For many of my patients who've had relapse, it's not because they presented with a platelet count of 5, it's because they run in the platelet counts in the mid 200s, and now all of a sudden it's 148. And we are treating them as though that, and at that point, so I feel that we catch it earlier. So I would not, it's probably, I wouldn't say that relapses tend to be worse. If anything, they tend to be not as severe as that first god-awful one where, you welcome to the world of TTP.
I completely agree that most patients are, I guess they become more vigilant after a diagnosis of TTP. And in fact, they actually get in touch with their hematologist with each minor complaint they experience. And I think it's good to be vigilant rather than presenting late. And most of the time with second or third episodes of TTP, we try to pick it early and treat it early. There may be a very few, I guess, minority of patients who may lose response to the standard treatments. And in those patients, especially when we have patients occurring where relapses are occurring multiple times, sometimes we may not see response to the regular treatment with steroids and plasma exchange, or they may need longer days in the hospital with plasma exchanges when they come back with the third relapse or a fourth relapse. In those cases, we may have to use stronger immunosuppressive medications.
All right, and we have another participant that joined us. If you want to go ahead and introduce yourself. Thank you for joining.
Hi, sorry, I'm a little bit behind. My name is Frank Aqua. I'm a hematologist at the University of Rochester.
Thank you. We were just discussing TTP relapses for acquired patients. And the next part, are you guys aware of any specific triggers for relapse? And would somebody want to explain the 2-hit theory so that patients are aware when we're discussing that?
As far as triggers, I mean, we've always felt that viruses, infections, anything that sort of activates the immune system is something that can do this, is something that can prompt or increase the risk for another relapse. And as for the 2-hit hypothesis, I think we have that just because we look at people, like you've heard mentioned, there are people who walk around with undetectable ADAMTS13 levels. Mm-hmm. We know this from the patients who have congenital TTP. And it's not as though they are in a constant state of a thrombotic microangiopathy. So while we know that ADAMTS13 deficiency is necessary to develop TTP, it's not sufficient. There has to be some other thing or other things. So it could be a 2, 3, 4-hit hypothesis. And what that other thing or those other things can be, we don't know. We're not that good. We're not that smart. We're still trying to figure it out.
You're exactly right, Aaron. I mean, the Paul Coffo's a French study that looked at this in women who presented with their first ever TTP episode when they were pregnant. A larger than expected number of patients were found to have congenital TTP. So what does that tell us? It tells us their entire life they had undetectable ADAMTS13 activity. Pregnancy, a known trigger for TTP, was necessary to sort of uncover their disease. So they'd lived 15, 20, 30 years of life without getting into trouble until pregnancy triggered it. So that's the best example. We don't know how many people are out there walking around with low or undetectable activity. But it's thought that you need both. You need the levels to be very low and something to sort of trigger or push you into that disease.
Perfect. And for patients that are congenital patients that aren't acquired, would somebody just speak to the difference in treatment? So why would coate be a feasible option versus plasma infusion for those patients?
I think one difference between congenital and immune TTP would be that there would be no role for immune suppression in congenital TTP. And that once we sort of made the diagnosis of congenital TTP, the necessity for plasma exchange is, I would say, is not as high, or, I don't want to say it's not there, period, but that wouldn't be that would be the first thing that I would want to do. Anyone else want? And I don't want to keep answering.
Yeah, I mean, you're fine. It's really the difference between being born without the ADAMTS13, and we just have to replace it, and the acquired form where your body creates antibodies against your own ADAMTS13. So if you just give them the plasma, their antibodies will destroy that as well. So that's why the acquired or the immune mediated, we remove the plasma, which removes antibodies, and put in donor plasma, which has the ADAMTS13. And congenital, we just give them the plasma.
Okay.
Do we answer, what about, does anyone answer the question about FFP versus Kuwait?
Oh,
That was the other part of the question, right, Claire?
yep. Sorry,
Yes.
you're right. Caught us there.
Yeah, well, I mean, the only difference is with Kuwait, which is, what's called a low or intermediate purity factor VIII concentrate. Not that it's like dirty or anything, but in terms of it's not pure recombinant factor VIII. It's derived from plasma. So so they took FFP and they did some sort of proprietary, filtering, fractionation, to make it higher in von Willebrand factor and factor VIII. It's also been found to have rather high levels of ADAM-TS13. So instead of having to give 2, 3, 4 units, let's say, of FFP, you could essentially just give a syringe, a squirt of Kuwait, and in theory, give someone 100% ADAM-TS13 activity back.
Yeah, I think a lot of it derived from the United Kingdom when they had issues with the blood supply and mad cow disease. I think that's where much of it started. But it's also a commercial product that you can self-infuse at home, like a hemophilia patient might give themselves clotting factor. It seems to be less used in the States where we tend to use more plasma for whatever reason, but it's a very reasonable option with Kuwait.
Awesome. All right. So recently, CRISPR technology has come to the forefront of some discussions. Would somebody like to explain what the CRISPR technology is and why it's being inquired about for congenital TTP?
I'm not aware if there are any studies on TTP using CRISPR.
No, I don't think there are. I mean, it's essentially kind of a gene editing type of technology where it can fix the altered genes. Still very experimental, I think. I think it's not every gene can be fixed the same for a lot of reasons unique to each gene or each mutation. And I think the interest in doing a study also is going to be a function of how many patients there are to treat. And if you have less patients to treat, it's not that it's less important, but it's that a company might focus somewhere else sort of sooner, especially early on when you're trying to prove that the technology works and is effective. So I don't think there's any ongoing studies. Reasonable to consider why or why not it's been applied to congenital. It's hard to really say. Probably some technical reasons that are above our heads to know for sure.
So essentially the thought is that this gene editing technology would be able to modify the genetic defect that makes it so that the patient doesn't have ADAMTS13.
Yeah, the idea, exactly. In the same way that you wouldn't do this, but a liver transplant can give you normal production of proteins that you didn't have before because this liver doesn't have that genetic defect. Again, it's a drastic approach. I'm not saying CRISPR is drastic, but it's sort of an approach like that to, if you will, cure the disease.
Okay. All right. Well, that is good. Let me pull up next here. The next question pertains to women of childbearing potential. Would you ever, I don't want to say like allow, but advise your patients it may be possible for them to have a healthy pregnancy? This patient has been told she should never have children, and it's pretty devastating for her.
Yeah, there's enough data out there that really tells us that if you are pregnant and if your ADAM-TS13 activity is low, you're at risk for relapse. But that doesn't mean you can't be pregnant. That means you need to sort of plan ahead. Some people will measure the ADAM-TS13 activity leading up to pregnancy, even treat with rituximab in anticipation of trying to get them through pregnancy. I think what it does require is a motivated patient and an experienced team of doctors that includes a high-risk OB, a hematologist, maybe even the blood bank to get you through that pregnancy. So can it be done? Certainly, but you need to be with the right people to help you get through it safely. It might be completely uneventful, but you got to be able to manage that risk. What do you guys think?
I agree.
Can you hear me? I wasn't
Yeah,
sure. I wasn't here.
go for it.
I wasn't hearing anything for a while. Yeah, I completely agree with you. And I think it also, it's patient dependent. So it depends on the patient and what their relapses have been. So if it's somebody who's had a very severe relapse or severe complication, and the treating physician feels like a recurrent event may be devastating, then that may be part of the reason why they are making that recommendation. But I do agree with Dr. Cataland that just having the diagnosis doesn't necessarily mean you cannot. It just has to be done with the multidisciplinary providers being involved, having that discussion ahead of time, and having a plan that if and when they do have a relapse, this and that is what they are going to do. I think that's really the key.
Okay.
Yeah, and it always helps to be, as Dr. Catalan was mentioning, it always helps to be, in good hands. When you're planning for pregnancy, it's good to have your ADAMTS13 checked and plan ahead on how to monitor that and how to, I guess, like reach out to help when you really need that, and establish care with OBGYN who's familiar with TTP. So at our center, we have a high risk maternal fetal medicine, and most of the academic centers usually have OBGYN physicians who are specialized in taking care of complicated patients. So it's good to be, I guess, like to start establishing care with them early ahead, and be available for frequent lab checks and frequent visits with your physician compared to the other pregnant people.
Mhm. No, I mean, I've had patients that have gone through pregnancy. We've had some that have relapsed in the midst of it, but others that have gone through. And I think, I would like to, point out that for many OB-GYNs or maternal fetal medicine, the priority is on the health of the mother. And if there's a possibility that that pregnancy might exacerbate an underlying condition, whether it's because they have a mechanical valve, they've got a malignancy, there's another autoimmune disease. They're not infertility physicians who are looking to get someone pregnant. They're looking more at what is going to be the health of the mother during pregnancy. And that is their priority. So, but that being said, yes, we can get, as long as we know that if the ADAMTS13 levels are up, it's been a while since the latest relapse or initial episode. With close monitoring, it can be done. It's just going to be more intensive than a typical pregnancy.
Yep, it's going to be more work. So you need a motivated patient that understands the risks and the benefits, and easier to prevent rather than treat TTP during pregnancy. So you really have to think 2 steps
ahead of time. Yeah.
Yep, and that's where you need that experienced team that's doing that.
Okay. All right. So as far as medications, are there any medications that can cause your platelets to drop or cause your ADAMTS13 to drop that you would recommend patients avoid?
I don't think we need to avoid any medications per se to prevent your blood counts from dropping or ADAMTS from dropping. But usually when patients have low blood counts, we tell them to avoid any kind of pain medications that may increase the risk of bleeding. And some of the herbal supplements that may interfere with your blood counts and cause more bleeding complications or low blood counts. But other than that, I don't think any of the medications would interfere with ADAMTS13 level.
Yeah, I would agree to that. And the only thing I would add to that is that there are specific medications that are known to sometimes trigger it, but that's usually, again, in specific circumstances. And one example I'll give is something like Tacrolimus, which we use for organ transplant rejection. And we know very well those medications, they fall into a class of drugs we call calcineurin inhibitors. And those drugs can sometimes cause sort of acquired TTP, not necessarily immune-mediated, but they are acquired in that it's triggered by a specific medication. And so if you've had something that has been triggered by one of these medications, then the recommendation will be to avoid that medication, but not necessarily sort of a broad generalization for other medications. They are usually these specific medications that we do know about.
Okay, and when it's stated that certain medications, certain pain medications can cause a little bit more bleeding, are those NSAIDs that you're referring to, or is there specific other medications that people should avoid or be concerned about if their platelets are low?
Yeah, mostly NSAIDs, like Advil, Aleve, over-the-counter pain medications, and sometimes antiplatelet medications if they are taking it for other indications. For example, if someone has an underlying heart problems, I think they should always discuss their medications with their physician, either the primary care physician or their hematologist, and so that they're aware of all these medications that the patient is taking and when to hold some of these medications.
Gotcha.
Yeah, but I would add to that, but it's important to realize that these medications aren't necessarily causing TTP relapse or affecting the Adams TS13. What they do is they inhibit the way your platelets act or the platelets work. And that's why you get bruising, but they are not necessarily causing Adams TS13. So I think it's good to know that.
Yeah, no, I want to take what Frank said a step further. If you have a relapse of TTP, your platelet count will drop. That's part of that. But you want to be careful. But just because your platelet count drops doesn't mean it's a TTP relapse. There are other causes, many medications that can cause a low platelet count, not necessarily causing a relapse of TTP. So you have to be a bit careful. And you're always very cautious with someone that has a history of TTP, but it also has to look clinically like it.
Right.
So you have to be careful.
Now, this question came in, and I kind of like it because it's different than the other questions we received.
Well, if Claire likes it, we're going to like it, I'm sure.
Yeah. So because TTP is so rare and there's so few actual diagnoses, how did you each become interested in TTP, or how did you each get into the realm of TTP?
Oh, wow.
Yeah, no, I like it because we don't really get to talk much about you guys.
I don't know if we have enough time to answer that question. I mean, for me, I love, like, you know, this field, benign hematology. You can see, like, behind there, like, it's just, you know, I find, you know, on one hand, we talk about Adams TS13 and von Willebrand factor and how this, you know, it's this the concept of balance. It's the homeostasis of hemostasis. On one hand, we have these ultra large pathogenic multiples of von Willebrand disease, which causes this thrombotic disease. And on the other end of the spectrum, we have disorders of von Willebrand, which we see far more common, von Willebrand disease, which is a bleeding disorder. And it's just, you know, I find this the whole process, the whole background behind this fascinating in terms of, you know, this alteration in balance. I find that because there's not enough data, that there's more work that needs to be done because you have patients with this. I find that sort of, you know, energizing is not the right word, but motivating. Like, you know, how can we improve this? This is, you know, I can't believe in this day and age we haven't found a cure yet. And, you know, I don't know. I mean, it's just, I find it fascinating, and wanting to improve it is that motive. Wanting to make it better is what sort of, you know, drives me. Sorry, I'll be quiet.
So you've always been a little nerdy is the answer.
A lot nerdy. Who are we?
Go ahead, Frank.
No, I agree. I think it's one of those things, especially with I know Dr. Metjian said, Aris said a benign hematology, but we always joke they are usually not very benign, right? So if you have somebody with a TTP and have a pretty severe complication, it's really not benign anymore. But the point I'm trying to make is that because one, it's very rare. For patients, it tend to be very challenging because, especially if you go to community hospitals or if you go to an institution that don't have a lot of people who are involved in the care of these patients, sometimes it can be challenging because they feel like after diagnosis and treatments and the platelet count is fine, then they are left to the world. But the patients usually know that something isn't right beyond that. And so sometimes they will sort of see different providers. And to me, the frustration that some of the patients had expressed to me after having seen them after their maybe second or third sort of relapse, that's what really got me interested in that. There are these sort of population of patients that need a lot more help than seeing the provider one time during the hospitalization, getting treated and feeling like, okay, now you are one and done. But in reality, that's really not the case. And I think more and more we are finding out now with a lot of studies coming out showing that there is usually, one, there is a lot more relapses, so it's usually not a one-time disease. Two, there are residual effects that some patients would experience beyond that, even if it's a single episode. And so that is, to me, what got me interested in studying this, and of course, getting to know Dr. Cataland and the rest of the team at USTMA who also have that interest. And I think that I would say galvanized all of us here to a degree. I can't speak for all of you, but I would say at least to me that's one of the pieces.
I think to me, early in my training, benign heme cases were always the most challenging and fascinating. I guess like it was more of a detective work to tease out what's wrong with the patient. And coagulation pathway somehow always fascinated me on how they came up with how the reactions happen, and the clotting and bleeding disorders were somehow the most interesting cases that I have had as a trainee. That kind of ignited my passion into benign heme. And as far as TTP goes, I think it's the acuity on how the patients present. And I have seen, so I did a year of transfusion medicine fellowship, and I have seen patients die in the ER while they were waiting for their placement of lines. And it was very heartbreaking to see how quickly these patients deteriorate, and to see the delay in care. Most of them are coming to us from outside hospitals where they have been admitted for several days, and unfortunately there was a delay in recognizing the condition or offering treatment because plasma exchange is not available at all centers. And it's gratifying to see how these patients turn around so quickly within 2 to 3 days of treatment, and to follow them long term, and how involved they are in their care. And I think it's more gratifying to establish that connection with these patients. I think TTP is always like one of the fascinating diseases for all the trainees.
Yeah. Well, I got off the rails very quickly in college, majoring in finance to do the opposite of my father, and graduated in finance. But midway through, kind of realized maybe I'd be better suited to medicine. And of course, went into medicine because I thought blood was interesting. And I was supposed to be a leukemia doctor. It's lasted about 2 years. But all throughout medical school, residency, and fellowship, I always found TTP to be very interesting. And like you've heard from my colleagues, it was something so serious and life-threatening, but yet you could turn it off and calm it down, and they could go back to a normal life. Now we're learning there are some long-term issues, but really to be able to fix something that was so catastrophic was fascinating. And I've always been drawn to that. And when I sort of switched gears in early 2000s, benign hematology made perfect sense to me for all the reasons they've already said. It's sort of logical at times. It makes sense. And I like the longitudinal relationships. You know, some of our patients we've taken care of now for 18 years. And the first patient we enrolled in the study is still with us now 18 years later, doing great. So it makes it a lot of fun, I think.
All right. Well, that's just, you guys are just awesome. So thank you for sharing all that.
We know you too well, Claire. You don't mean that.
No, I do. I like hearing about it. I knew you were a finance major, and I've heard the leukemia thing before, but
Yeah,
hadn't heard from everybody
that was
else.
a long shot to get out of high school, so I was doing well when I got to college.
Yeah, that inspires some confidence in your medical treatment. All right. So couple of questions that have come up. The first one is length of time to treatment. So how essential is it or does it make a difference, the length of time a patient is in a TTP episode before they actually receive treatment? Like, how important is immediate care for these patients? And what are some of the barriers that new patients coming in may have before they get diagnosed?
I would say immediate care is critical. And I think my colleagues here would agree with me, because if we go further back in the, I suppose, the beginnings when um, people started thinking about TTP, or before plasmapheresis became sort of readily available in a lot of institutions, the mortality or people dying from TTP was very, very high. You're talking about 80, 90% of the patients who did not get appropriate treatment, early on died. And now it's really almost completely flipped around, right? Where 90% of the patients, if they are seen in time, the diagnosis is made sort of early on, and plasmapheresis is instituted, they do very well. They do very well. So time is of the essence. Like they say in stroke, time is brain, or maybe I'm wrong about that, but that's really what they say.
Right.
And I think it's the same thing with TTP, because some of the patients do end up with strokes and have debilitating sort of effect from that. So it's pretty much the same thing. And so time is really critical when it comes to TTP.
I think sometimes people think of a low platelet count and bleeding, but this is a clotting disorder. So we think the longer your platelet count has not recovered to normal, you're still forming these clots using up these platelets. So we think the quicker you get to a normal platelet count, it's a marker for we think you're not forming those clots anymore. But I think, most of us, we all work at reference centers. So we have patients that are already diagnosed many times with TTP and sent to us. It's a very challenging disease to diagnose. For the average physician to see one or two of these throughout their career, especially an ER doc who's got to worry about 150 other things, these are not easy to diagnose. What might be obvious in hindsight at the bedside is not so easy. It takes a physician that's able to think on their feet and also think when something doesn't make sense and kind of rethink their initial ideas. So it can be tough to diagnose.
Okay.
Yeah, but I think I echo what Dr. Akwa says, that this is, emergent treatment, urgent treatment. I mean, this is not something that we would recommend you just wait on and delay, because there's, to me, that's a gamble. The patient might do fine. They might be perfectly fine if you've waited a day or two or a weekend, but that's, it's unacceptable.
I think we have gotten better in recognizing TTP compared to a few years ago. Most people are able to at least suspect TTP when there is severe thrombocytopenia or drop in platelet count and other lab studies which are suggestive of TTP. And sometimes when if the patient has high suspicion for TTP, and if there is no possibility of doing a plasma exchange right away, I think we sometimes tell them that draw a lab level for ADAM-TS13 and probably give some plasma while we are waiting for the patient to be transferred to an academic center or another hospital where plasma exchange can be done.
Yeah, sometimes we say the hardest part about diagnosing TTP is just thinking about it. And if the physician thinks about it, kind of the light bulb goes off. But sometimes in the middle of everything, it gets tough.
Okay, so the next question is, when a patient is diagnosed with TTP, so, they show up, initial barriers getting the actual diagnosis. When they're diagnosed with TTP, why is it not initially done that there's genetic studies to confirm if it's acquired or congenital? Why is that an impractical option?
Well, I mean, it's early on, you just don't know. And either way, you'll treat them the same. So in theory, you could do genetic testing on every patient who comes in with a low platelet count, but then you're going to be doing thousands and thousands of genetic studies that are all going to be normal for what you're looking for. So when they present initially, they look the same, congenital and the acquired version of it. One subtle difference, and maybe not so subtle, is when you start treating a congenital patient with plasma exchange, they get better much quicker. And that's sort of a clue. We also look for the antibodies in the blood that are causing the low ADAM-TS13 level. So yes, he could, but it's just impractical to do it.
Yeah, and I'll add to that. The genetic test usually takes much longer to get back.
Yeah.
So to get a genetic test results, usually you're talking about 2+ weeks, sometimes actually 6 to 8 weeks, I would say, if you want to be realistic, about 6 to 8 weeks. Whereas for the Adams TS13, the inhibitor and the antibodies and the Adams TS13 level, you can get it back in most places within 2 days, within 48 hours. And so if you say, well, I think it's TTP and I'm going to do a genetic test without actually, doing the inhibitor assay, you'll be waiting that long just to get a results back. So practically speaking, it's not the most, the best approach. And so that's part of the reason. And two, if we do the Adams TS13 inhibitor and antibody assay, they come back and there is a high titer inhibitor or an antibody, then that gives us the answer, right? We know it's acquired, we know it's immune mediated. Then we don't necessarily have to go and do the more expensive genetic testing because we do have an answer from the inhibitor testing. And that's part of the reason.
Okay, and so if somebody has congenital, they wouldn't have any antibodies, or if antibodies are present, would that still be able to be congenital? This patient has, her son was diagnosed as congenital, but she's saying he had antibodies present.
There's some rare cases where, maybe not so rare, we just don't check enough, where patients who are getting plasma can develop antibodies against the infused atom TS13 in the plasma. So it's essentially like you can develop an antibody to red cells or platelets. But it's a bit different and distinct. They tend to be lower in quantity. They're not disease causing necessarily. They can sometimes lead to clearing of an infused atom TS13 or red cells or platelets. But not the same thing as your own body creating an antibody against it. It depends. It's more technical. Nobody wants to hear about it, but it's kind of how you measure it, whether it's an inhibitor titer or you can look for specifically the amount of the antibody that's there. And you can sometimes find them more readily that way, but it doesn't mean it's an acquired TTP.
Okay. So to end on a little bit happier of a note, because I've been told that this is a very depressing disease and that I'm making people sad. How do you think the landscape of treating at least acquired TTP and potentially congenital TTP will change in the next few years? So how has Capitalism changed it for patients with acquired, and what is in the pipeline that could benefit the congenital patients?
I think Capitalism has been a big game changer. Has definitely, I mean, this is the first and only FDA approved drug for TTP. And I think what we'll see is, my 2 cents is that, a big question is going to be, can Capitalism replace plasma exchange? We know, I mean, it's not the same, the studies have not been done, but we know there are lots of case reports where people who either refuse plasma exchange were unable to get it, they were able to have their TTP successfully treated with just Capitalism. So I think that's sort of question number one is, do we still need plasma exchange in the era of Capitalism? And I think the second thing that was, and then for congenital TTP is the next question would be like, well, when will the recombinant atom TS13 finally get FDA approved? That has been years in the pipeline. That molecule has spent almost more than a decade trying to get to this stage. So I'm excited for that.
My turn. I think the disease has had remarkable transformation from being nearly uniformly fatal to nearly all people surviving. And I think we're right on the cusp of another big transformation. Like Era said, I think this disease will be treated in the future without plasma exchange, with more directed therapies like Capitalism and some others. And it wouldn't shock me in the next 5 years if many patients are treated as outpatients or even just one day in the hospital managed as an outpatient. I think we're coming to that. So it's, I think, reason to be optimistic.
Yeah, I agree that recombinant atom TS13 and Capitalism are probably the game-changing medications in the world of TTP. I guess as more people are surviving from TTP, I think the future research in TTP is going to focus more on long-term complications of TTP, trying to avoid cardiovascular complications, and how best to follow these patients in the long term after they have had TTP episode for several years after the initial episode. I think probably we should focus on more of long-term outcomes.
I agree.
Yeah, and I would add to that, this one of the things that I think moving forward, hopefully we can learn more about, is to be able to predict who is going to get a relapse, right? If we can predict it, or stratify and see who is the most likely to get a relapse in the next, say, year or two, then we can potentially modify their monitoring or their follow-up, and perhaps sort of treat them either prophylactically or intervene early enough that it doesn't, if they get relapse at all, it's not severe. But the hope is that it doesn't happen at all if we can detect it early.
Great. I really appreciate everyone signing on here. Anybody who hasn't had your questions answered, email us at admin, ADMIN, at ustmaconsortium.com, and we will get back to you. We send those to a board of physicians we have, and they answer them as soon as they're able. We actually have a very good turnaround. We also are working on redesigning our website and making it more user-friendly and more patient-friendly and having additional utility to it. So wait to see that coming forward. In addition, we are also working on creating some patient resources. So we've had a couple questions on how to gain access to rituximab, or how to get notes for HR, how to access FMLA or disability payments. Email us and we can work with you. I have a couple of resources that we've created. And we'll be able to get those going, but watch for our website rebranding. And thank you for everybody for joining. Thank you so much to the physicians for being with us and ending on kind of a higher note there.